Hi, my name is Mary Vukicevic and welcome to Eccentric Viewing Training Part 2. In the first part we learned about what eccentric viewing is and the definition of PRL versus TRL, or preferred retinal locus versus trained retinal locus. And we discovered some of the pre-training considerations that we need to take into account before we start eccentric viewing training, and also how to work out what the correct trained retinal locus should be. Now we're going to move on and we'll actually step by step go through how to conduct an eccentric viewing training program. So step by step, firstly we need to locate the most viable TRL, make the patient aware of the potential acuity of this retinal point, and then teach them the distance and the direction of the refixation movement. So for example, the patient needs to look to the left and approximately 7 degrees from fixation. We also need to provide adequate repetitive practice and teach an application to a variety of circumstances. And finally, if the patient requires it, we need to teach reading skills. So step 1 is actually described as scotoma awareness. So what you need to do is you need to introduce something to the patient that has quite a bit of detail on it, like a playing card or an Amsler grid, and you place it in the patient's primary position. You ask the patient to look directly at it, and what will happen is the scotoma will cover the detail on the playing card or across the Amsler grid, and the patient should then concentrate on defining the edges of the scotoma while they're looking at either the card or the Amsler grid. Often what will happen is the visual system will fill in the scotoma and the patient may not necessarily be entirely aware of the boundaries of their scotoma. They need to know where the scotoma boundaries are so that they can eventually, with eccentric viewing training, move that scotoma out of the way. So I'd like you now to do a little activity. What I'd like you to do is stare at the cross in the center of the gray area which is covering this playing card. While you're staring at the cross, what details in the periphery there can you actually perceive? Can you tell what the letter on the playing card is? Can you tell what the symbol is? Are you able to clearly see other features that define the Jack's facial features, his eyes, whether he has a mustache or not, for example? Now what's important is that you make sure you don't keep moving your eyes towards what you want to look at. This urge is irresistible, and the same thing happens to patients with central vision loss. It is a very frustrating exercise, you'll find, if you are staring at that cross and trying to determine what other features you can notice on that playing card. What I did forget to mention to you is you should be seated about 35 to 40 centimeters away from your screen in order to do this task, and the screen should be enlarged so that the image takes up a large proportion of the screen. If the image is too small, it's going to fall within the boundaries of your macula, and it'll defeat the purpose of the activity. So with the activity, I'm just trying to illustrate to you how frustrating it is to have a central scotoma, and also that that irresistible urge that I just explained of wanting to constantly refixate and use your fovea to see things. So step 2 in eccentric viewing training is what we call refixation, and that's where you ask your patient, after you've determined what the correct trained retinal locus will be, ask them to make a refixation movement away so that the scotoma no longer falls on the object that they're interested to see. So for example, on the left side we've got a picture of the cow, which is in the very center, and then above and below, to the left and to the right of that cow, we have some dots. So the uppermost dot, which the red arrow is pointing to, is 5 degrees from fixation. So if the patient's trained retinal locus is 5 degrees inferiorly, what we need to do is ask them to look up at that dot there that the arrow is pointing to. Make that dot disappear. That means place the scotoma over that dot, and then hopefully they'll be able to see the cow in using their trained retinal locus. That's using the Eccentric Viewing Home Resource Kit, which has these different cards with different objects on them. That's one method of training refixation. Another is using an ECView module, which, as is shown here, the same principle applies. On the right hand side there, what we have is a cross and the word shut underneath. So the patient makes a refixation movement superiorly, they make the cross disappear, and then the word shut will actually appear in the healthy area of macula, just under the foveal zone there. Now, this module is actually showing a 4-letter word. However, you probably, if you're starting out, you should just introduce single letters or shapes or numbers perhaps, rather than something as complex as this kind of 4-letter word. It's a little bit too hard in the early stages of training. You can also give verbal directions for refixation. So going back to the playing card, you can hold the playing card in primary position and ask the patient to look at the image so that it disappears. Then they're to move their eyes slowly, for example, superiorly, and stop when they can first see the image peripherally. You'll need to remind your patient that the clarity in that zone won't be so good, of course, because now we're going beyond the fovea. And remember, visual acuity decreases exponentially as we move away from the foveal zone. Step 3 in an eccentric viewing training program is practice. You need to give your patient plenty of practice while increasing complexity, and you can vary the print size and add complexity by introducing sentences or longer words. And if you are using pictures for practice, you can decrease the picture size and increase the detail. I often tell my patients to practice while the news is on of an evening and watch the television, and it's a good opportunity to practice eccentric viewing because the TV screen's usually quite large, they sit fairly close to it, and often there's a newsreader on for long periods of time so that they can practice their refixation and see if they can pick out the newsreader's features as they're practicing. And you can see there the different types of practice opportunities that are shown through the ECView modules, the left side and also in the middle. In the middle is a sentence, and you can increase the complexity by increasing how many lines you actually are showing to the patient at any one time. And then the example on the far right hand side is a practice book from the ECView Home Resource Kit. My apologies, from the Home Resource Kit, which is the one that's associated with the cow picture and the smiley face picture, and the patient, can use that at home and practice their eccentric viewing. They can also practice on newspaper headlines and any other activities. Step 4 is a wider application. So you need to suggest to your patient to practice at home with objects such as a clock or crockery on the table, photographs, for example, watching television, as I explained before, or going out into the garden. That's a good opportunity for practice too. But remember, they shouldn't try eccentric viewing while they're walking around. They should stand still and then apply the principles of eccentric viewing that way. Then we come to step 5, and step 5 is related to reading. You'll find that some patients need to gain advanced reading skills to enable them to remain competitive in the workforce or for their studies. So you should build up from single words to well-spaced words to normal text eventually. And you'll find that these patients are usually younger patients, and also they are much more motivated to be able to read than perhaps an older patient that only requires spot reading for various daily living tasks. So these patients are often more challenging, and you can get to step 5 with them, and that is get them to read fairly fluently. Other things you need to do is teach them line changing techniques, which I'll show you in a moment, and also introduce line guides and possibly reading boards. So here's an example of the reading modules in ECView. On the left-hand side, we've just got one sentence available for the person to read, and on the right-hand side, we've got 1 or 2 paragraphs. So that's another method of increasing complexity for the purposes of reading. This slide here shows 2 things. One on the left is showing a reading board. So book stands and reading boards like the one shown on a flexible arm can be helpful for positioning text in the right place. So depending on how close the patient needs to hold the object that they're reading. And on the right hand side, we've got an example of a line guide. And you'll notice that the line guide is just pretty much a piece of dark cardboard that has a hole cut in the middle of it. And you can easily make these for your patients or give them instructions on how to do this themselves. And what it does is it isolates that one sentence, and so there's no distractors superiorly, inferiorly, and that facilitates reading. Now, I mentioned previously about reading and line changing techniques. Now, conventional reading, as shown in the top, is where we're moving from left to right across a sentence, across a line, and then we make a refixation movement which is diagonal over to the beginning of the next line down. And so on and so forth, and that's how we read. When you're teaching someone with vision impairment to read, they need to read slightly differently because they will often lose their place on the page. So what you need to do is get them to read across the line as you normally would, but then when they get to the end of the line, they shouldn't make that diagonal refixation movement, because it's at that diagonal refixation movement that they're going to get lost. They should go back to the beginning of that line that they just read, and then the refixation movement should be a more simple one, just a straight down movement to the first letter of the next line, and so on. So this tends to be quite helpful when patients are reading, especially if you're teaching them eccentric viewing. And then step 6 is relaxation. Now, you might have noticed when you were doing the task with the playing card that trying to notice what's in your peripheral vision is quite difficult. And so it stands to reason that eccentric viewing also takes a lot of concentration, especially at the beginning of the training. Don't forget to give your patients a break. You should stop for a chat, get them to look out the window because they're doing a near task for a long period of time. Stand up, walk about, stretch, and so on. Now, for those of you that are wondering, a typical eccentric viewing program, I find, takes about 45 minutes per session. Any longer than that, and I find that the patient just tires too much. And any shorter, and I just don't think you're offering enough training. So I'd say approximately 45 minutes. Sometimes if they're highly motivated and perhaps a bit of a younger patient, you can get away with a 60-minute training. So it is quite intensive. In the next slide, I'm just showing you something called the Plateau period. And when I was working with patients with central scotomas and teaching them training in eccentric viewing, I noticed that there was a period of time where they actually plateaued and didn't show any improvement in their near vision. So what you'll see there is a table. The participants are shown on the left. There's 10 participants in this small study that I conducted, and their near print size is shown under number 1 at the start of training. So patient number 1 or participant number 1 had a near print size of N96 font at the first training session. This improved to N36 at training 2. Then they had a further improvement at N24 at training session 3 and 4. These training sessions were approximately 1 week apart. In week 5, you'll notice that participant 1 actually regressed. So in week 4, they were showing able to read N24 font. In week 5, that decreased and that went down to N36. We pushed on, and in week 6 the font improved again and it went down to N24, and then by week 7 it dramatically went to N12. Now this doesn't happen with all patients, as you can see there, but it certainly happens with the majority of them, and I found that plateau occurs at around weeks 4 and 5. So what does that suggest? That suggests that firstly, 1 or 2 training sessions in eccentric viewing are not enough, because as you can see there, the range of visual acuities or near visions that the patients are showing at weeks 1 and 2 are not that good. But if you push on past weeks 7 and 8, they actually do improve quite dramatically. And you also have to get over that hump of the plateau period in about weeks 4 or 5. So my suggestion actually for training in eccentric viewing is an optimum number of sessions is at 8. If you can get away with more than that and the patient is motivated, then certainly I would keep going. But I think a minimum of 8 sessions is optimal based on the research that I've done. So when do you actually stop? Well, you stop when the patient is able to recognise the current print size that you're working on fairly well but can't see anything smaller, or when they can just recognise a print size but they can't read it. So what you do is you enlarge it by 1 print size and stop as you're training, or when the patient is able to do the tasks you agreed to during the initial planning. So for example, you might have said that their goal would be to recognise faces more easily, or watch television, or look at photos and so on, read newspaper headlines, for example. And if they feel they can do that and don't want to continue with training anymore, then that's okay. That's an ideal time to actually stop, and they might have enough training under their belt to make it worthwhile for them. So I have some references here that are quite useful. The first one is from 2012, and that is entitled "The Simplified Method of Identifying the Trained Retinal Locus for the Purpose of Eccentric Viewing Training." And in that paper I actually describe the smiley face test and the Jerem tangent screen, and check to see whether or not there's some compatibility across those 2 tools for identifying the trained retinal locus. And as it turns out, there is quite a lot of compatibility, so it is a useful tool, the smiley faces, to identifying the trained retinal locus. In the next few articles, eccentric viewing training in the home environment and vision rehabilitation, my apologies, and then the 2005 one, rehabilitation strategies used to ameliorate the impact of centre vision loss, I talk about the studies that show that you can actually get quite a good improvement in near vision with eccentric viewing. And the final one is the effect of eccentric viewing on the visual function of persons with age-related macular degeneration. So have a look at that too. And then if you're interested in vision rehabilitation and the development of eccentric viewing training, there's a brief historical overview published in the Australian Orthoptic Journal as well. Okay, so that concludes the information that I have for you related to eccentric viewing training. Good luck.